It is really such a pleasure to be here. A few years ago at one of the hospitals in which I serve as a member of the ethics committee, a 40-year-old patient who was being treated for cancer of the palate was brought into the emergency room suffering from delirium. He was subsequently admitted to the ICU for treatment of an overdose. The patient, who had an extensive history of alcohol and drug abuse, was reporting cluster headaches and made very specific requests about the type of medication he wanted, along with the method of delivery. 2 injections, 15 minutes apart, 1 in each buttock. The covering physician was not only concerned about what he identified as drug-seeking behavior, but also about the effects of the requested medication on the patient's already precarious respiration status. As a result, the doctor ordered the nurse on the floor to administer a placebo. She adamantly refused, at which point the physician became belligerent. When the case was brought to the ethics committee by the nursing supervisor, we talked not only about the ethics of giving placebos, but also about the phenomenon of moral distress experienced by the nurse who was ordered to do something that she believed was unethical. Indeed, the term moral distress was coined by philosopher Andy Jameson in 1984 within the context of nursing ethics to refer to situations in which institutional and organizational cultures coerce people into doing something that they believe is unethical, but they also think they have no choice. Since the identification of the experience of moral distress as a potential consequence of decision-making for nurses, there has been considerable research concerning its impact on both the professional and personal lives of individuals. Today, moral distress continues to be a common topic in the nursing literature, with one recent study reporting as many as 80% of nurses having experienced medium to high levels of moral distress, and more than 15% of nurses have left their jobs as a result of it. Increasingly, however, there's a recognition that nurses are not the only healthcare providers who are experiencing moral distress, and that this condition is having an equally deleterious effect on physicians. Consider, for instance, the role of physicians in advocating for treatments that an insurance company deems experimental for a patient, but which has been accepted as protocol in another state for a decade. Or responding to pressures as a member of a group family practice to see growing numbers of patients for shorter periods of time under a system of relative value units. Or conveying concerns to administrators about the volumes of electronic medical records that are now being produced and which one suspects may actually undermine rather than enhance patient safety. Maintaining one's own professional autonomy while both negotiating with families out of a genuine concern and commitment to shared decision-making and addressing the demands of risk managers. Each of these acts can cause moral distress among physicians. And though doctors traditionally occupy a different position in hospital hierarchies than nurses, social workers, and other members of the healthcare team, they are at times no less constrained by the institutional forces that lead to the fallout from these types of ethical dilemmas. Ethical dilemmas, by their very nature, are such that no matter what course of action one takes, there's some ethical principle that will be violated. It is the continual overriding of what one regards as the correct moral principles that leads to moral distress. In my experience as an ethics committee member for community hospitals, for teaching hospitals at major universities, biobanks, and state health departments, undoubtedly the most significant rise in instances of moral distress among physicians relates to end-of-life issues. Though ethical issues at the end of life are nothing new, Americans' deeply entrenched attitudes about death are a contributing factor in an apparent shift regarding the types of cases that are being brought forward. So my objective for tonight is to detail some of the challenges for contemporary bioethics with respect to decisions around death and dying in the United States, and to discuss how physicians and bioethicists can work together to address our common objectives related to providing the best care possible at the end of life. I want to begin by contrasting two cases that represent what I regard as the transition in the nature of ethical dilemmas related to end-of-life issues. The first case was relayed to me by my family practitioner during a visit to him. So while I was sitting on the examining table, clad in my paper gown, I waited as the doctor was finishing his typing of notes into my record. Without turning around, he said, "Let me ask you something. You're still on the ethics committee, aren't you?" And he said, "My partner has this case, and I was wondering if you could help me with it." He went on to describe an 88-year-old post-stroke victim who was hospitalized repeatedly for congestive heart failure, diabetes, recurring pneumonia, open wounds, and staph aureus. Each hospitalization involved a 3 to 4 week stay in the hospital. Throughout these stays, the patient was intermittently conscious and incompetent to make decisions for herself. Since she was unable to swallow, she was being fed using peripheral lines. The patient's daughter, who would leave her side only occasionally to sit in her car, insisted that everything be done to keep her mother alive. It was during the most recent hospitalization, when a mass was found in the patient's lung, that questions of futility arose. The daughter demanded that a biopsy be performed and wanted surgery if the mass turned out to be cancerous. The medical team was convinced that the patient should be allowed to die, yet the daughter was intent on doing everything possible to sustain her mother's life. What's frustrating, my doctor confessed, is that the staff feels like we're torturing this poor woman. But the last time we were able to have a next of kin declared incompetent to make medical decisions, the hospital risk managers and lawyers insisted that we do everything to keep the patient alive anyway. As I was listening, I kept thinking about what a radical departure this case was from the types of cases that we dealt with as an ethics committee when I first began practicing medical ethics in the mid-'80s. Then almost all of the cases involved patients and their families demanding the right to refuse life-sustaining treatment in order to die what they considered a natural death with dignity. One of the most compelling cases centered on a physician's self-described moral distress. It was brought to us for retrospective analysis, and it involved a 60-year-old patient who had been suffering over the previous few months with what the doctors termed multiple vague symptoms. She had aches and pains, and they couldn't really find out what was wrong. But the last panel of tests revealed that she was dying from liver cancer. Her primary care physician met with her to discuss the diagnosis and the prognosis. And while the patient was understandably shaken, she was seemingly accepting of her fate. The doctor talked to her about whether she wanted a living will, and she signed a living will saying that if the burdens of treatment outweighed the benefits, she wanted to forego extraordinary measures and die a natural death with dignity. She made clear that she didn't want to be resuscitated if death was imminent and she suffered a cardiac arrest. So a copy of the patient's advance directive was placed in the doctor's office and in the emergency room. The day after the conversation with the physician, the doctor received a call that his patient was being transported to the emergency room by ambulance. She had been discovered in her bed by her husband. She had swallowed a bottle of tranquilizers, and she had cut through her wrist with a hatchet. She was in cardiac arrest when she was brought into the emergency room. And the family physician who was brought to the emergency room agonized over what to do. He knew that if he acted aggressively to save this patient, she likely would have no good days ahead of her. He said, "I took an oath to first do no harm," this Hippocratic oath, and he suspected that death would be less burdensome than life itself. But he thought, well, if I treat her aggressively, she's going to be furious. And he knew also that in the state in which this occurred, that assisted suicide was a felony. He also knew that living wills are not binding in cases of attempted suicide or in cases of women who are pregnant. He felt that he had no choice, so he performed CPR. He stitched her up, intubated her, and as he suspected, when his patient regained consciousness, she was furious. She tried to rip the tubes out. She demanded that all treatment be stopped. A psychiatric consult was brought in. She was deemed competent to refuse treatment, extubated, and died 6 hours later. Though at first convinced that he had ultimately done the right thing under the circumstances, the physician regretted his part in prolonging his patient's suffering. In this case, he truly believed that prolonged existence might actually bring about more harm than would death. Moreover, he wondered whether a law allowing for physician-assisted suicide would have given this woman the assurance that she needed, that she would not be forced to suffer needlessly if death were imminent, a type of assurance that may have prevented her from attempting to actively take steps to end her own life with or without the assistance of another. Moral distress arose from the fact that the physician believed that in order to meet his obligation to his patient based on a duty to both non-maleficence, to do no harm, and to beneficence, to relieve suffering, that he would have to go against his own self-interest in violating a legal code. In weighing his self-interest against the interest of another, he was forced to come to grips not only with his patients, but with his own humanity. It was perhaps confronting the commonality of experience that enabled the physician to engage in a consideration of this case from a variety of perspectives, including a feminist perspective when we were discussing it in committee. By doing so, he came to understand how imbalances of power that are based on gender play themselves out in medical practice and in the theory surrounding that practice. As a result, he came to understand that the moral distress he experienced was in part due to the realization that the patient's right to refuse life-sustaining treatment as an expression of the right to autonomy needed to be considered in the broader context of a society in which women are conditioned to be caregivers and may be psychologically pressured into choosing death rather than being an economic or emotional burden on family members. Side by side, these cases illustrate the type of radical change that has emerged as ethics committees confront end-of-life issues brought forward by physicians. Yet while there's a movement away from cases involving the right to refuse life-sustaining treatment toward those centering on futility, in both instances, the moral distress results from a common cause. We live in a society in which technological advancements precede thoughtful reflection about the ethical, legal, and social implications of the use of that technology with respect to when and how patients should be allowed to die. In the future, society will not be able to continue to avoid ethical and policy issues inextricably linked to the use of medical technology. Thus, questions that policymakers need to address in open discussion include: how should we as a society allocate scarce medical resources? Can individualism be excessive in matters of life and death? How can we balance the values of pluralism and tolerance on the one hand against principles of fairness to all on the other? And most importantly, should society continue to view death as a failure and thus distinctly un-American? In order to meaningfully address these questions, we need to confront two emerging trends in medicine. The first is the tendency to interpret patients' autonomy rights as including the right to demand whatever treatment is necessary for sustained existence. The second is responding to such cases with a liability-driven ethic. It's important to note from the outset that these trends are not only interrelated, they are rooted in and bolstered by a deep-seated proclivity in American society to want to avert death at all costs, and to avoid any open discussion of death. Indeed, the rhetoric over the past few years surrounding various proposals for healthcare reform highlight just how uncomfortable Americans are when talking about death. In a culture in which television viewers are barraged with invitations to ask their physicians about treatments for erectile dysfunction, depression, high cholesterol, arthritis or fibromyalgia pain, and a host of other maladies, there was a staggering amount of Sturm und Drang over the proposed inclusion in a healthcare reform plan of a provision that would reimburse physicians for talking to their patients about advance directives and other end-of-life issues. Rumors of death panels and invocations of Nazi euthanasia programs led politicians to excise the proposal early on from the House Tri-Committee bill. The furor started, as you may recall, with Sarah Palin's Facebook page, asserting that if government passed healthcare legislation, boards would be set up to determine whether the elderly and the disabled were worthy of care. On August 7, 2009, she wrote, quote, "As more Americans delve into the disturbing details of the nationalized healthcare plan that the current administration is rushing through Congress, our collective jaw is dropping, and we're saying not just no, but hell no. The Democrats promised that a government healthcare system will reduce the cost of healthcare. But as economist Thomas Sowell has pointed out, government healthcare will not reduce the cost. It will simply refuse to pay the cost. And who will suffer the most when they ration care? The sick, the elderly, and the disabled, of course. The America I know and love is not one in which my parents and my baby with Down syndrome will have to stand in front of Obama's death panel so his bureaucrats can decide based on a subjective judgment of their level of productivity in society whether they are worthy of health care. Such a system is downright evil." Though garnering the most attention, Palin was not the first to raise these types of concerns. Her post followed an earlier editorial in the Washington Times on how government plans for more funding for health information technology could be compared to Nazi eugenics programs. In addition, the former Lieutenant Governor of New York, Betsy McCaughey, commented on a program hosted by radio talk show host Fred Thompson that, quote, "Congress would make it mandatory, absolutely require that every 5 years people in Medicare have a required counseling session that will tell them how to end their lives sooner." She misstated, perhaps out of genuine confusion, the real intent of the legislation, which was to have Medicare pay for optional appointments to discuss living wills, healthcare directives, and other end-of-life issues. In the weeks that followed, there were statements issued by politicians warning against a policy that would push us toward government-encouraged euthanasia and the need to protect seniors from being put to death by their government. President Obama responded by maintaining, quote, "Some of people's concerns have grown out of bogus claims spread by those whose only agenda is to kill reform at all costs. The best example is the claim made not just by radio and cable talk show hosts, but by prominent politicians, that we plan to set up panels of bureaucrats with the power to kill off senior citizens. Such a charge would be laughable if it weren't so cynical and irresponsible." By disavowing the truth of the claim of death panels in this way, President Obama failed to address the real fear underlying the concerns of those who readily believed the rhetoric, namely the denial of necessary medical care at a time of urgent need. Thus, an opportunity was lost for meaningful debate over critical end-of-life issues that were pushed aside during the process of political jockeying. My goal here, especially on Election Day, is not to drudge up partisan debates, but instead to draw attention to the nature of the fear expressed by individuals across the country. People are genuinely concerned that the government will be allowed to determine what constitutes necessary care and who should be allowed to receive it. Americans want such decisions to be made by families in consultation with their doctors. yet they fail to fully understand the extent to which the current norms, which discourage conversations around end-of-life issues, serve to thwart their ultimate desires. Americans' inabilities to confront our inadequacies around death should not come as too much of a surprise to those who are familiar with the medical literature. In the mid-1990s, the Journal of the American Medical Association published a series of research papers resulting from a 10-year, multi-million-dollar study on how we die in America. Sponsored by the Robert Wood Johnson Foundation, the study to understand prognoses and preferences for outcomes and risks of treatment, the support study, was the largest, most widely publicized research project examining end-of-life issues. It revealed that dying in America has been unnecessarily painful, isolating, and costly as a result of physicians either not understanding or ignoring their patients' wishes. While designed to improve end-of-life decision-making and lessen suffering, the support study revealed that none of the interventions that were introduced significantly influenced any of the outcomes that they were designed to improve. Over 50% of the patients reported dying in moderate to severe pain, with the extension of life not correlated with an improved quality of life. The results of the support study were so shocking to the funding agency that Robert Wood Johnson commissioned a series of papers done by the Hastings Center, exploring the study's conclusions as to the circumstances in which many of us die and how difficult it is to make that process any better. In the end, the funding agency reported, quote, "One of the most insightful explanations of the support results pointed to a popular and medical culture that so forcefully resists the notion of death that families, healthcare practitioners, and patients themselves are unwilling to ask questions and make the kinds of decisions that would diminish the fear around the dying process in this country." To illustrate this point, in an article entitled "How We Lie," Boston University ethicist George Annis recounts Sherwin Newland's experience with a patient, Hazel Welsh, described in his best-selling book, How We Die. Welsh was a 92-year-old arthritis victim who suffered a perforated digestive tract after a fall. Though competent and adamant in her refusal of treatment, Newland persists in his attempt to persuade his longtime patient to undergo surgery. Welsh agrees reluctantly because she trusts her physician. The operation is more complicated than expected. The suffering is intense afterwards, and the patient dies from a stroke 2 weeks later. While Newland at first says that he would have done things differently after this experience, he recants upon reflection. It's a lie, he admits, for surgeons do everything, no matter what the cost to the patient, rather than risk the scorn of their peers. Newland remarks, quote, "It is in such matters that ethicists and moralists run aground when they try to judge the actions of bedside doctors because they cannot see the trenches from their own distant viewing point. The code of the profession of surgery demands that no patient as salvageable as Miss Welch be allowed to die if a straightforward operation can save her life. And we who would break the fundamental rule, no matter the humaneness of our motive, and do so at our own peril. Viewed as a surgeon, mine was a strictly clinical decision, and ethics should not have been a consideration." Annis emphasizes that physicians are taught to do everything, and if there's nothing else that can be done, then don't talk about death. He's convinced that under these circumstances, the only way for there to be a change in the quality of dying is to take individuals out of hospitals before they die, or to never admit them in the first place. If a competent patient clearly expressing her wishes is not listened to, what chances do we have of being listened to when we are no longer competent? Annis suggests that our attitudes about death and dying are too deeply ingrained to be able to make a difference. A decade and a half after the release of the support study, little has changed. Americans are still reluctant to talk and think about death. For this reason, the process of dying, particularly in the hospital setting, is often characterized by feelings of abandonment and a loss of control on the part of patients and their families. Anticipation of a hospital death is often overwhelmed by fear that dying will involve a complex strategy designed solely to maintain vital functions rather than to address human suffering. This fear is not unwarranted, given that more than ever, death has become a negotiated process rather than a discrete event. In the absence of meaningful collaboration, patients may be subject to over-testing, over-treatment, and rehospitalization at the expense of the quality of life during one's last days. The reality is that the vast majority of Americans who die do so in healthcare institutions following a decision between the physician, patient, and family to forgo treatment. As a consequence, bioethicist Nancy Doubler contends that, quote, collaboration and negotiation will need to replace the raw exercise of power that appealing to futility represents. Exercises that, in and of themselves, will require more meaningful conversations between families and healthcare providers around death. Fortunately, there's cause for optimism around recent attempts to create institutional infrastructures and organizational cultures for facilitating such conversations. Three are worth special consideration, along with attention to the challenges they face. The first is the movement of states taking up where the federal government left off in terms of promoting conversations around the best care possible at the end of life. For example, in my own state of Massachusetts, the Senate passed a bill a year ago in May to promote palliative care awareness. At the heart of the bill was a regulation requiring each licensed hospital, skilled nursing facility, healthcare center, or assisted living facility to distribute to patients in its care information regarding the availability of palliative care and end-of-life options. The information and counseling is to include the prognosis, the risks and benefits of various treatment options, and the detailing of the rights to comprehensive pain and symptom management at the end of life. The encouragement of such open conversations will assist healthcare teams in understanding patients' views on whether the burdens of treatment are likely to be regarded as overriding the benefits. The mandate is to offer the information. It is important to note that patients still have the right to refuse engaging in the conversation and to decline the offer of making end-of-life plans. The Massachusetts proposal follows similar existing legislation in Michigan, California, and New York. The Michigan Dignified Death Act requires physicians to inform their patients with reduced life expectancies of the recommended medical treatment and alternatives, along with the risks, benefits, advantages, and disadvantages of each option. Patients are also informed about their ability to appoint someone to make healthcare decisions for them if they become unable to do so, and their ability to receive, discontinue, or refuse treatment, and their ability to achieve or to choose palliative care treatment and pain and symptom management. Similarly, California's Right to Know End-of-Life Options Act requires healthcare providers make counseling available to terminally ill patients upon their request. And as you may know, under New York's Palliative Care Information Act, healthcare providers must offer to provide counseling upon a terminal diagnosis. While the hope is that this approach to dealing with end-of-life negotiations is the first step in training hospital and home care staff to comply with their patients' wishes, the provisions do not extend nearly far enough. Conversations should not be initiated at a time when patients are their most vulnerable, physically and emotionally. Instead, these conversations should take place as a part of initial, routine, and ongoing visits to physicians. Authentic decisions, ones reflecting the deeply held values of patients, have to be demonstrated throughout the patient's life. And these are enhanced by evolving conversations as the burdens of illness and the benefits of treatment are continually assessed. Having integrated conversations regarding end-of-life issues as the standard of care is the most desirable approach, given that legal mandates often do very little to change the culture that has served as the impetus for reliance on the coercive power of the law in the first place. Nevertheless, the legislation provides a pivotal starting point, and we should utilize as many strategies as possible to encourage physicians to discuss the goals of any particular treatment within the entire span of a patient's medical history. If this occurs, decisions of medical futility and palliative care, when necessary, will be less stressful for both parties in the physician-patient relationship. However, the real and sometimes urgent need for physicians to be direct and straightforward when discussing medical futility and the goals of palliative care should not be lost. This need was at the center of a controversial case, Arado versus Avedon, involving the nature of informed consent. Upon his death from pancreatic cancer, Arado's family sued his surgeon and oncologist for giving Arado too much hope by offering chemotherapy and radiation without outlining the statistical morbidity and mortality of those with his condition. While the plaintiffs argued that an understanding of statistical life expectancy was an essential component of informed consent, the doctors emphasized that Mr. Arado appeared to have such anxiety about his condition that it would have been medically inappropriate to hammer home the unlikelihood of success. The oncologist, Dr. Avedon, argued that in his experience, patients in Mr. Arado's circumstances wanted to be told the truth, but they didn't want a cold shower. He argued that it would be medically inadvisable to deprive the patient of all hope, which would be the likely result of full disclosure of the high mortality rates involved with pancreatic cancer. Besides, as each of the testifying physicians argued, the statistical data cannot accurately predict what will happen in any specific case. Even so, studies indicate that a physician who is not direct can inadvertently mislead a patient about his or her prognosis and treatment goals. Arado versus Avedon makes abundantly clear that when a ruling of negligence comes down to the question of how much hope is too much hope, institutional vectors for engaging in these values conversations become critically important. Barriers to these types of values conversations extend beyond the doctor-patient interactions into interactions among teams of healthcare providers. This is particularly true with the advent of hospitalists. Since their introduction onto hospital healthcare teams, much research has supported the use of hospitalists as a means of offering the best care possible at the end of life. Hospitalists emerged in the mid-1990s, reflecting a new model for acute patient care. Because they are based in hospitals without the demands of a separate medical practice, the notion is that hospitalists will be better able to coordinate care for hospitalized patients in a manner that both controls costs and better serves the needs of individual patients. By the very nature of their work, they offer enhanced accessibility, familiarity with hospital policies and practices, and extensive experience in addressing the physical and psychological needs of hospitalized patients. Nevertheless, the pervasive use of hospitalists has added a layer of complexity with respect to end-of-life issues. As primary care physicians spend less time with their hospitalized patients doing rounds, the most immediate challenge is that as the attending physician of record, hospitalists are often required to make treatment decisions in consultation with patients and families that they've just met. It can be difficult to meaningfully engage in a values inventory to inform treatment decisions with a patient who is sick enough to be hospitalized and with whom one has no prior history. Moreover, the addition of another specialist onto the healthcare team increases the potential for ethical conflict. Oncologists, hospitalists, and palliative or primary care physicians may have different perspectives regarding the aims and purposes of treatment. If the oncologist is recommending treatment that the hospitalist believes is futile, there may be a reluctance on the part of the hospitalist to challenge the oncologist in promoting a comfort care strategy. Thus, medical students need to be taught not only how to discuss end-of-life issues with their patients, but with one another as well. The goals of medicine consist in healing, sustaining life, preserving functions, and alleviating suffering. Professional commitments based on the goals of medicine guide behavior and they serve as a model for adjudicating cases. In end-of-life situations requiring collaborative decision-making between a patient and healthcare team, values conversations are essential for protecting patients' rights. A third approach to reversing current trends around end-of-life decision-making is described by Joe Klein in a fairly recent cover story for Time magazine. Klein writes about his 5-month experience as a participation in the type of collaboration and negotiation around end-of-life care for both his mother and father, who were suffering from dementia. In the end, he says, quote, "My parents died serenely, with dignity. When you are the death panel, when the time and manner of their passing is at least partly in your hands, that is the very best you can hope for." Klein believes that the difference in the quality of the dying experience for his parents was a result of his decision to transfer them from a regular fee-for-service Medicare program to a private nursing home that used the Geisinger healthcare system, in which physicians are paid salaries and outcomes-based performance bonuses rather than by the services they perform. Klein may be correct in his assertion, but the reality is that very few patients are afforded this option, or even the choice of which doctors are going to handle their end-of-life care. The best we can do to protect patients' rights, then, is to lobby for end-of-life discussions as a routine component of medical practice, to incorporate this training into medical school curricula, and to educate patients about the importance of engaging in these conversations. The persistent under-referral and underutilization of hospice care reflects the reality that most medical students are not taught in medical school anything about hospice or palliative care, because these rotations are not required. Bioethicist Rebecca Dresser reminds us that, quote, "In today's medical environment, bedside ethics is as important as it ever has been. Too many clinicians lack the skill, opportunity, or the will to have these difficult conversations that patients and their families cope with at the end of life. And we live in a culture, as we've said, that continues to treat illness and death as alien events, leaving patients and their families to struggle largely on their own." Major changes around the medical culture and patient advocacy have occurred in the past when individuals have come together to call for reforms. Yet, as Ira Byock jokes in his most recent book, The Best Care Possible, quote, "Being mortal is too broad a category to generate a special interest group. Instead, physicians need to come together as a professional community to ensure adequate mentoring around stopping life-prolonging treatment, encouraging people to fill out advanced directives and pain management directives." Nevertheless, these efforts must extend to community conversations at the grassroots level if they are ever to take hold. This is where bioethicists can play a critical role by serving as public intellectuals, conducting workshops with community members around end-of-life decision-making. The community context is key. When I taught at the Brown Medical School, I used to use my colleague Al Killaley's book, The Politics of Being Mortal. One of the most important points he makes in his work is that it is not death we fear as much as it is the annihilation and absurdity of a meaningless life. For him, it is only through a recognition and acceptance of human interdependence that meaning can be given to both death and life. And it is only through greater candor about death that the anxieties and fears of citizens will be lessened and meaningful dialogue will ensue. Indeed, until we're willing to have a national conversation about the impact of a more open treatment on death, of issues of social justice, I suspect that many of my doctor's visits will continue to be ethics consults. For healthcare providers are likely to experience ever-increasing moral distress over how to abide by the Hippocratic oath's enjoinder to first do no harm in a society in which death continues to be viewed as patently un-American. So thank you. I'm looking forward to having a conversation about these issues.